palliative care.
Thank you. Thank you very much. So I enjoyed Ted's talk, and I totally agree with what he's been talking about. The other thing I would add to the college guidelines is it specifically excludes, well, the latest iteration completely excludes patients in residential care. And that's what you need to know. And so what I've done is if I've had someone in the community whose pain has caused dysfunction and that, I've said this person is basically a person who would be in residential care. And the fact that I'm treating her pain will keep him will keep them more functional and hopefully keep them out of residential care. Because it's not hard to show that pain causes poor function, and poor function leads to deconditioning, to increased frailty, and the next thing you know, you're in residential care. So, however, until a college punishes someone for not prescribing or under-prescribing, I won't believe a damn thing they say until they do that, because I've always maintained there's a double standard, right? And if you do overprescribe, you get raked over the coals, and I've had it many times. And remember, nobody's ever lost their license from, lost their ability to practice medicine because of opioids. You can lose your prescribing pad, but you never lose your license. And it has to be really problematic. So never fear an audit from the college, because it's a pain in the ass and it takes a lot of time. But I think you get the chance to think things over and think, this is why I do this. This is what I've done. And as Ted says, if you've been using your clinical judgment, I don't think you need to have to worry about anything. But as I say, until they remove that double standard, I would feel a lot better if I saw that they said, someone was found to have fired patients or not, said, I'm not prescribing opioids. Now, I wonder about all the walk-in clinics, because they're supposed to be your family doctor after 2 or 3 visits. So it'll be very interesting to see what they actually do. So I do have a disclosure, and you wouldn't believe it now, Purdue Pharma, every time I say that, people disregard anything you say about opioids. I'm hoping you won't. I have talked for Purdue for years when nobody was talking about pain management, and when nobody was talking about palliative care. They funded a lot of it. But I'm only talking about generic names anyways. I never use brand names. So just to counter a bit of what Ted said about studies, I mean, I couldn't agree with him more about you have to be a good consumer. But these studies that linked prescribing to opioid deaths are big data studies. And I think you need to be very wary of these studies and understand what they actually are. To put the pro part of them first, people love it because it's a sample size of 1 million, And then they say, well, this is actual practice as opposed to sterile research setting, right? Something to be said for that, but we can talk about that in a bit. Easily available data, and of course it's way cheaper than the randomized controlled trial, which are getting so expensive that many people just don't want to do them. And of course, decision makers love data, and if you can produce large of it, they like it. Theoretically, you compare across settings and societies, and it's got good accuracy of the null hypothesis if the study's been done properly, and we'll talk about that. What is the con? The main con that people seem to forget about is observational studies are not causal. You cannot say there's been an increase in prescribing and this increase in prescribing has led to overdose deaths. It's only an association. Why? Because you're missing a huge amount of data. And that's the thing a randomized control study does, is controls it, right? Now, people can say, and, I'm not a statistician, so I know they can do lots of fancy things to try and account for that. But everyone will say, when you look at these big studies at the end, they'll have limitations, and they will say these. Quality of data input. Most of you people are probably familiar with the MDS, right? Does it make you nauseated just hearing about it? Yes. And believe it or not, this stuff is being used to make decisions about care, right? Huge problems I saw when I was involved in MDS and residential care. Half the time a person came in, they maybe had one assessment and died. You can't use this to follow people. So I won't get started on it. But anyways, it just drives me nuts because, like, for instance, is the patient palliative? There used to be a question about that. So, I know my nursing colleagues would look in the chart to see if they could find palliative somewhere. If they couldn't find it, sometimes they said no, when in fact I, as a physician, looked at that person and said, I doubt if they're going to last 2 months in here. So you see, not only was there missing data, because sometimes you couldn't fill it all in, but also sometimes it may not be that accurate because you're relying on some people to write a word that most people don't want to say, unfortunately. The other thing is, a lot of people say they're doing this MDS just because they have to, right? Not because they want the best ever research to come from this. And so sometimes it's just like the billing clerks or not necessarily billing, but MSP clerks or whatever in the office, or people who are looking through at the end of the discharge summary. They're not doing it for research. They're doing it for other reasons, right? So sometimes you don't get the full story. There's also a huge lack of patient-related outcome measures. The number one in the studies we're talking about is pain, really. Now, some of them did have pain, but a lot of the times they don't. So if you look at the studies that say opioids cause people to fall, they never really consider how much pain the person had, whether they had a gait disturbance or not, whether they were cognitively impaired or not, because that can sure cause you to fall. So there's a lot of problems there. Also, pharmacy data, and any pharmacist will know this, what's dispensed is not always what's taken, right? And they don't equal that. And then the assumptions that are made, which I find the one that drive me crazy, is that if you're on opioids, your pain must be gone. And we all know that it's a process, right? Getting someone's pain under control. And then all opioids are the same. All opioids are not the same. And that's one of the huge problems with these studies. So that's my take on it. Unlike Ted, I don't really believe that the increasing prescription of opioids has caused opioid deaths. I think the inability to screen properly for addiction and the lack of treatment resources for addiction has led us into this problem. But I know a lot of doctors personally feel frustrated that they're being blamed in the papers for this. So it is problematic. Just to show you, I said all opioids are not the same, and I want to show you an interesting study because people always say, well, all the opioid studies are just compared to placebo, so of course it looks better. Nobody ever does a head-to-head trial. So a bunch of palliative care people and oncologists got together and thought, well, if we could randomize 1,000 people to receive morphine, oxycodone, buprenorphine, or fentanyl to manage cancer pain, we could see, it would be a big enough sample to see the variations because there's tremendous individual variation depending on your genetics. But if you had a big enough sample, you'd see this. Well, unfortunately, they didn't get the big enough sample. They got half of that. But it's still pretty damn good. And what they did is took people who are maybe already on opioids or maybe not and put them on 30 milligrams a day of morphine or morphine equivalent or 60 milligrams a day if they were already on that. And then they kind of began to adjust the doses to treat their pain. And they had 4 groups. And they looked at how people responded to the opioid, what kind of side effects they got, what they had to do to get pain control. Pain control was considered at a level that was acceptable to the patient. What they found is, which is always surprising, is that about 25% of people were poor to non-responders. And I think those of us who do treat pain realize that opioids don't work for everybody. And there are certainly poor responders, and you have to keep switching. And big table, but what I want to point out is that there are significant differences. So does this work? It does. You can see that people had to up the dose of fentanyl a lot. That's probably because of that very difficult gap in what equals what, in the variable rate. Does anybody know why there's such a, when they say a 25 microgram patch equals, what is it now, is it 60, somewhere around 45 to 130 of morphine? Does anybody know why there's such an enormous range? No? Okay. Yes. Had to do with, partly you're right, but partly, yeah. And what'll help you tremendously, it's the same reason why it takes 12 hours to kick in. Why? It's because it's highly lipophilic, and it loves to be in fat. And it has to saturate fat tissue first before it spills over and starts to work, in other words. And as you know, young people tend to have loads of muscle and not much fat, and us older people tend to have more fat and less muscle. So you see this wide range of dosing because it's different. So frail older people tend to need lower doses for that reason, and it's stronger, so to speak, because they will absorb. They could absorb less of it, so you might say, well, you have to use more, but then you get sort of a poor responder state, so it gets very confusing. But keep in mind that fentanyl is often needs more adjustment. Percent requiring increased dose, that's pretty much the same. You'll notice that they had to rotate fairly often. So the idea that, well, I put everybody on one opioid and we just stay on that doesn't cut it for a lot of people, right? We have to switch. Stop due to toxicity. This is what I often see. Morphine is generally not well tolerated or less well tolerated than other opioids. And this is because these people even did not have renal failure. if we had people in here with renal failure, we'd see a lot more intolerance to morphine. And confusion, look at the differences here. So there are differences. And so when you throw all opioids and say, gee, they're all the same, you get studies that aren't very accurate. In general, opioids of choice in frail elderly and renal failure, hydromorphone is better than morphine and codeine, but all three of those, you can get active metabolites that accumulate in renal failure. Fentanyl, much better tolerated in older adults. And I would say one of the reasons why you don't want to use 2 opioids at once is because you can start getting accumulation of active metabolites, and then you don't know which opioid is doing what. Methadone and buprenorphine, both well tolerated in older adults because they don't have active metabolites. So the study that Ted showed, the effect of opioid versus non-opioid medications on blah, 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 blah. That's the title of it. Anyways, in the abstract, the interpretation of the study, we conclude, results do not support the initiation of opioid therapy for moderate to severe chronic back pain or knee and hip osteoarthritis. Okay, you might think, when you read this study, it's appalling. It actually got accepted, really. For one thing, the median pain score was 5. That means that half the people had a pain score less than 5. You probably wouldn't even start opioids on someone with a pain score of 3 or 4 or something like this, right? So that's not real practice, right? The non-opioid group was able to be treated with tramadol. 10% of them ended up on tramadol. To me, that's like, come on, guys. Does not distinguish between mechanical back pain and neuropathic pain. Now, there's a huge difference between mechanical back pain and neuropathic pain, right? And yet they didn't distinguish that. And the populations were actually quite different. For one thing, the opioid group was more employed than the non-opioid group. And usually it's the other way around, if anything. But they weren't equal. So there were lots of problems with this study. However, how did it show up in media? Medscape said, more data confirms that opioids are no better. Now, what did I say? These studies are not causal, right? But you see what the titles say. More data confirms opioids not best. And then CBC, prescription opioids, no better than over-the-counter drugs. So you can just imagine all the nephrologists in BC going, oh, shit. Because everybody's going to run out and buy over-the-counter drugs, right? I mean, and even in the Canadian Family Physician, the fellow who did the Canadian guidelines didn't like the article I wrote, dissing the guidelines. And he disputed the fact that NSAIDs were more deadly than opioids. And I don't know where he's coming from. The main thing is that NSAID deaths don't cross the college desk, okay? It's true they are mostly older people, but that's ageism and, problematic in itself. So anyways, and then there was something called Vox Media, finally proof opioids no better than other medications for some chronic pain. So it's really sad to see this. The other thing is they had people with moderate pain, yet they made the conclusion that even severe chronic back pain or osteoarthritis didn't merit opioids, which is reaching way above where their study went, I think. So, anyways, enough of that. I could go on for ages about it, but if this is the future, I'm very discouraged, because this is like science with an agenda, right? As opposed to sort of making sure that we've got the science right and then seeing what the conclusion is. There was also a recent study that came out showing they had a bunch of patients with cancer, and they knew they had cancer, and they looked at their pharmacy data and then how long they lived. And they concluded that, my God, the people on the high doses of opioids died sooner. We better be careful with these opioids. I am not kidding you. And that got published in a journal. What are people thinking? You know? So it's very concerning. And I must say, the one that you thought was a good study, I would say to GPs out here, how many people find that the people who tend to have the risk factors for addiction are the ones that come to you again and again saying, I can't stop these medications yet. I can't stop these medications yet. It's a self-fulfilling prophecy that the person who took the medication longest ended up with an addiction problem. If you read this study, you find they only looked back at prescriptions for 6 months prior to the surgery. And they, in the limitations, it said people who, we did not have any further information about whether people might have risk factors for addiction. So to me, it's like, well, yeah, sure, they're going to be at your office the most wanting to continue the prescription, right? I mean, we know that adverse childhood events are strongly related to misuse of opioid medications. And we now have all kinds of scales like the opioid risk tool and things like this. And I always put my patients through that. Sometimes I even do that to reassure them that they're not going to, that the risk is really low. So be careful what you read. It's very difficult because you don't have a lot of time for reading. So anyways, this was a lovely 90-year-old guy, and he was actually a general practitioner. And he and his wife worked together in the office. And then when they retired at age 75, he thought they should continue to do things together. So they took up Argentinian tango. And he kept this up, and remarkably, he was in an incredibly good shape. He had really bad congestive heart failure secondary to congenital atrial septal defect. But he was 90, right? And he kept active. The brain is young, but the body isn't. And he thought he could just move this thing, and he fell backwards. Immediately felt pain, and he struggled for months. Family physician gave him Tylenol 3 for pain. But, of course, then he had to choose between pain and constipation, and he chose pain. After months of ongoing back pain, he finally went to the hospital. And as often happens, and I don't know why we do this, he was found to have a troponin elevation. It wasn't that much. And in someone who's in congestive heart failure, I suspect you'll often find that, right? So he was carted off to internal medicine, I think, against his better judgment. But they did send him back to try and address the back pain, and it showed multiple compression fractures. And he was treated with PRN, acetaminophen, and oxycodone. What do you think about that? Yeah, I mean, PRN, a guy who's used to, anyways, he left. He refused to, I bet a lot of doctors go AMA, right? I mean, nurses are second to doctors in being bad patients, but I think doctors are the worst. So there he went. He went to a regional pain clinic, and he was given Tramadol, in addition to Tylenol 3 and acetaminophen. And then the GP, feeling terrible because this guy's still having pain, gave him an NSAID. And within 10 days, but at least he monitored his GFR. And within 10 days, it dropped from 35 to 21. And he discontinued that, and it made no difference. So the family physician gave him a prescription for hydromorphone, 1 milligram, told it to use it only when the pain was really bad. And this was actually prior to the college standards, okay? But I think a lot of people get concerned, and with frail older people. But you see now, he was using a combination of Tramadol, Tylenol 3, acetaminophen, and hydromorphone. What do you think about that? It's just like, it's a recipe for disaster, right? So when I met this gentleman, because my colleague called him and said, what do we do? Because he was saying, just let me die, I want to die. He'd had enough, right? It had been 18 months since his compression fracture. So we admitted him to the hospital, started him on low-dose sub-Q infusion of fentanyl. I love to be able to do this with frail older adults because you can get their pain controlled quite fast. So within 24 hours, we had his pain at rest controlled on 25 micrograms of fentanyl. But the problem is every time he stood up, he just got intense pain and he really just couldn't walk. So we talked to our radiologist colleagues and they did a CT scan. Sometimes they'll tell you to do an MRI, and you need to talk to your colleagues first. And lo and behold, they see this, here it is, the big hole in it. Probably even non-union there in T12. And so you might say, well, that's funny because some of the studies show that it doesn't make any difference and some do. That's a population study. You're still going to have individuals who will have ongoing severe pain, right? And in them, if you still see marrow edema, that means they might have a non-union or still not have a proper healing occurring yet, and they may still benefit from a vertebroplasty. So if I have someone, even in residential care, I will call up my radiologist saying, what kind of imaging or whatever, do you think I would need? And they'll usually tell you, because if you're just doing a very short MRI from here to there, it's a lot quicker. And if they see the edema and they think they can do something, then they do. So with this fellow, they put in these giant needles. Never tell the patient the size of the needle. It's 11. Yeah. And so apparently it goes in like butter in someone with osteoporosis. It's terrible when it's somebody younger, right? Because it's hard to push it through. And one lady said to me, I thought I heard hammering, dear. Because they do. But the nice thing is they do give people some midazolam. And so, of course, they don't remember that they've been flipped over face down, because what macaroni, if you've got a lady who's shaped like this and you tell them they're going to be lying face down, they would refuse to go, right? Because they say, dear, I haven't laid face down since the 50s, or whatever. They're very good at, people never say, do you know what they did? So if you get someone who's skilled at it, it's good. And as I say, I totally agree that the studies Ted mentioned showed that it is very controversial. Keep in mind that those are population studies. You still will have individuals that may benefit if they have severe ongoing pain. So the next day he was up walking. Now this guy is kind of extraordinary, right? Because he was very mobile anyways. And he did still need regular opioid to control his background pain, because as you can see from his CT, he's a mess, right? I mean, it's terrible. So he actually got good enough pain control that he was able to go out and take in a double feature movie, which he always insisted his wife go to. Whether, was she interested? Who knows? But anyways, he did die 5 months after due to his congestive heart failure, but he really benefited from this. So we're going to take a break.
We're going to take a break.
So if I may just point out key learnings. Okay. So I told you vertebroplasty can still work. Speak with the radiologist. I love sub-Q fentanyl infusions. I know you can't do it in residential care, but for those of you who do it in acute care, it's marvelous. And of course, NSAIDs can be deadly, but I think Ted made that point. Okay.
So why don't you guys come back here at 1:45, 10 minutes. Thanks very much. And you can come ask questions of our speakers here.
Yeah.
Yes. Oh, I see. We'll turn that off.
I can turn it back on again.
Good.
I'm a nurse practitioner in residential care.
Okay, great.
Yeah, so I never heard you talk before. So what about methadone?
I'm going to talk.
Are you talking about methadone? Pardon me?
I'm going to do a case
Oh, excellent.
methadone,
Okay, good.
and
Yeah.
then I will. I wrote a paper, which is 2009, but it still talks about the mechanics of how to.
Okay.
Because I know you guys can now write for opioids, and
Yes.
I can't believe they removed the exemption off methadone. You know why it was put on? Because when people started using it, they couldn't use it. It killed a lot of people.
Yeah. So what do you mean remove the exemption?
Well,
For
you used to have to have a
Are you asking me hard questions?
About methadone. Yeah.
Yeah.
It normally works.
Some.
Mind you, it also sends the people over the edge occasionally when you, because they only pay for the liquid preparation, which is 10 milligrams per mil, and you got to get a microscopic eye drop, and it's better to have the patient by the 1 milligram tablets and break them in half.
We have someone who's 103 on methadone. Tiny 3 doses of cervical saved her.
And you know, I had a lady who was on, you'll never guess how much it took to control her pain, 200 milligrams.
Methadone?
Yeah.
And we've done it with like
and
2.
Of course, I know that's my usual dose, right?
Yeah.
But this lady was amazing.
Wow.
And she was still functioning. She'd answer her phone on the third ring and everything like this. Of course, she was at risk for an malignant, right? Because we're above the 100. But she said, never mind, dear. Quick end is a good end. But it's rare.
And also just a quick review of your process around, the vertebroplasty case study. So you have someone who falls, has a compression fracture, and then can't get rid of the pain, so go further with imaging. Okay.
Because, and I think you have to just choose your patients, right? You're only going to choose someone with severe pain.
Yeah.
Because that was the problem with a lot of the previous vertebroplasty studies. They had trouble recruiting, so they're recruiting people with a pain level of 3.
Yeah. So,
you're not going to see any difference. So it's really, or you try opioids and don't tolerate the opioids, so they get delirious on all of them, and you're thinking,
now what? Yeah. Okay, what brilliant thing is Dale going to ask?
I was going to ask you about dilaudid toxicity, because when I did my palliative care rotation in hospice, that was basically the girl that didn't have any metabolic issues, and it does?
Oh, yeah. So it's metabolized the same way as morphine and codeine through glucuronidation. The metabolites tend to be shorter acting and they escape easier.
So that's what makes it cleaner than morphine.
You'll see it if you get to higher doses, or you'll see it in people with renal failure. And so if I had someone who said, oh, time of morphine, it's out of my mind, or I don't know, I'd sort of think, oh, maybe I better do something. Having said that, I use a lot. But for really, really frail older adults, especially with renal failure or dialysis, like I certainly didn't use it on dialysis, and I'm going to go over a case about that.
So then fentanyl again is for
Methadone or buprenorphine.
How much is buprenorphine, whatever it is?
Cost?
Yeah.
Oh, it's what angers me about our government not covering any of these other opioids, right? They say you people are using, but they don't offer any other alternatives. I can't quote you prices.
It's kind of dear, I think.
It is if we get up to the higher doses, like 20 and 40. Providence Healthcare covered because our facilities are, the hospital kind of paying for it, and the hospital said, let's pay for it. And so the nurses loved it.
Yeah. Well, the nurses, I'm just doing strictly residential care now, and the nurses love dilaudid, and if that doesn't seem to work, certainly it's not known to work. And sufentanil. I'm just doing pain for those people, and methadone is something I just started.
And that's perfectly fine.
I don't use any NSAIDs, and half the time I get rid of the time, and all they do is everything anyway. There's just more pills to take.
I know. When you get rid of 8 pills, people really say,
yeah.
So
it tastes it really tastes bad too.
So something like dilaudid, you don't bother with Tylenol?
No, why?
Well, because of different mechanisms. I'm just going by.
Yes, I used to think
but,
that way too. But I found that getting rid of 8 pills when people are on handfuls of pills, they love getting rid of the 8 pills because they usually wondered why they were taking it because they were having so much pain taking all these pills and nothing was working. So I used to get rid of it.
I'm on a mission to demedicalize and right, so that means getting people off all the medications and teaching more as we suggest. And we've had some success, and we're going to keep on bashing.
What do you mean by demedicalizing it?
The people that are living in regular care.
And then
Be subjected to the kinds of things that people in the outside world are.
oh, you mean like tests and investigation,
Everything.
testing for disease indices? Because I am very much friends with medications because I don't want people to suffer.
No. I'm not talking about anti-suffering. If the medications for suffering they stay on, all the rest of the crap they get rid of.
Yeah, I totally agree with you. The statins
And hypertensive and all the rest of that crap.
Yeah.
Don't say that for the cat.
But because oftentimes pain or blood pressure goes down. I've seen that a number of times, right? Because,
If you're dealing with a demanded population, I don't even think that blood pressure measurements there, because when you're invading somebody's space, the blood pressure is going to go up. Now, if they're worried about them being, if they're going down, if you're looking for hypotension, that's a different matter.
Yeah. No,
but if you take them off all their drugs, they're not going to be
I'm with you. I used to get rid of lots of stuff with pleasure.
Hello, Dr. Gallagher. It's so nice to meet you. I'm here because I work in residential care, but I also have 2 people at home that I care for. One of them is my 85-year-old mother who had hip surgery. She has a cardiac history, had hip surgery in December, then was back in the hospital with 3 vertebral compression fractures. Now she's just spent another week in the hospital with another 4 vertebral compression fractures. Now they've shipped her back home again, not on enough medications. How do I get her to see you or Dr. Rosenberg? Or I have been fighting for much. We live in the Chosen, so it's sort of halfway between here and Sioux. I had my doctor, my family doctor, is concerned about the College of Professionals, and his, he's very good. He did allow me to come in without my mother to get a prescription for her breakthrough pain, because otherwise I have to have her there. And we live 25 miles, and I have to load her in a car. She's 85.
And what else does she have?
Oh, she's so died. But every time we get a prescription that just takes some of the pain away, that she's willing to go another day, the doctor won't renew it at that strength. So she's on 3 milligrams AM and PM of slow-acting hydromorphine with 1 milligram for every 4 hours for breakthrough, plus the 8 tablets. I don't know. I'm just looking for more help for her. She's doing well.
Because she was able to kind of, they were able to say, well, we think this was free of lungs.
She looks quite kyphotic.
I bet.
Right? But my mother's sister something like that. It's almost worked in her back. I mean, it's so for example, she's not anywhere near the maximum dose on 10 milligrams. No, and that's just, this is my husband is many years ago, 30 years ago. But in the meantime, he's raised their weight. So they take him off of the anti-inflammatory drugs and put him on to yes, so he takes 10 milligrams of night, which doesn't ease. And it's the same safety. There's Victoria. I took my father to that. My father passed away now. He had also. I'm not sure. I live so far away. I have to drive.
And I would say your mom would fit the criteria for palliative care. Someone in the community that does palliative care. I can't see people out of the
He's going to shoot me
area,
away.
but I'd be happy if you give, I'll give you my card.
Yes, please.
Okay, and then, because I could always talk to your doctor.
Thank you. Yeah, thank you so much.
Oh, you want to say something?
No.
Okay. Okay. Oh, yeah. Okay. Yeah, okay. I'll fill it out. Yeah, great. Thank you.
I like to see that energy in the room. Good job, everyone. Be excited about residential care. I'm sure you're excited about, that's what you're talking about so enthusiastically. Some awesome care plan you just developed today. I can't wait to tell you about this great thing I did with a resident. And how I'm going to go back and lower all their opioids, but not too much. Okay, good. So we're going to do some more cases, and then we're going to have questions. And I want you guys to write down your questions as you're going along, so you're ready for the question session, because we want to take good advantage of these experts in the room while we're here. All right, so get those questions ready, and I'll turn it back over to Romayne for case number 2.
So I have a sort of a potpourri of cases which we'll go through fairly quickly, and these ones I'm going to ask you guys questions. So 79-year-old woman, she had a CVA, left hemiplegia, recurrent TIAs, atrial fibrillation, osteoporosis, recurrent falls, you know, the usual, and breast cancer, dementia, and ESL. So the staff report that she was noisy and agitated with care, and they were trying loxapine. She was working her way through the system, and she'd been newly admitted, and they had tried increasing the antipsychotic in the late afternoon. What else besides her dementia could be accounting for her agitation? Pain, yes. Anything else? So there's lots of... Pardon me? UTI, yeah. Constipation, yeah. Maybe just being unfamiliar with the environment, lacking... all kinds of reasons, right? Yes. Yeah. Yeah, absolutely. So thank you. All kinds of reasons why. But
just if we're going to have lots of questions, make sure to turn on your mic when you answer them, or you can repeat the answer
thank you.
Really quick for the guys in the other room.
Thank you very much. I'm sorry. Yeah. So we were going to see her, but she fell again. Had an unstable intertrochanteric hip fracture, admitted to acute care, had a screw, had a screw. Woo! Pardon me. That gives the whole new meaning to orthopedic surgery, doesn't it? She seemed to be unable to follow directions and was resisting care and pinching the staff, and the diagnosis was that she had advanced dementia and they should just return her to residential care. I think you guys know this, and you think, here we go again, right? So in acute care, they were giving her hydromorphone 1 to 2 Q4 while awake and Tylenol 650 QID while awake. What do you think about this? Yeah, she wakes up in pain, yeah. And you're off to a bad start, and what if she sleeps a lot? She doesn't get much medication, right? So, okay. So she returned to residential care, and we started her on oxycodone, 15 Q12, based on what she'd been having in the hospital. And, you know, we went up to 50 milligrams in the morning, 40 in the evening. To get her comfortable. And we then looked at the opioid equivalents of what she was getting in the hospital, which was 40 milligrams of morphine a day approximately. And in residential care, she needed 135. So no wonder she was uncomfortable, right? So key points, while awake and PRN orders don't really work that well in dementia, right? And then older people generally require smaller doses, but I have seen some older adults who can really, they probably have genetics that explains this, but you have to base it not on what dose you are but on how their pain is doing and how the side effects are. And the dose that gives pain relief varies from person to person, and that's a major problem with the standard, is that it is not evidence-based. And by that I mean evidence of what we know, that there's huge inter-individual variation. So if you happen to have genes that make you a rapid metabolizer, you're in big trouble. Case 3, 68-year-old man with known advanced liver failure and dementia. Both thought to be secondary to alcohol. They probably were. And he was on our palliative care unit. So he was calling out, swearing, vulgar language. It was Russian, but it was apparently very vulgar. And he was kicking and resistant to care and would say little even with the interpreter. Here is his past medical history. So, and he wasn't dying, you know, he was kind of stabilized. So we were trying to sell him to residential care. And you can imagine you guys would not be buying, right? Because, resident still refusing treatment and irritable, staff had been hit. And so, we were having problems selling him. So I happened to be on, I guess I came on, and I thought there's something that doesn't make sense here, right? So what to do? I mean, what would you do in this case? So we've got him on some pain medication, but not very much, because after all, he's only got liver failure, and that's it. Could there be anything else going on? Pardon me?
Look for other problems.
Look for other problems, right? And so I asked his wife, because of course I'm not going to get a history from him. And interestingly, in chatting with her, she mentioned, oh yes, he got hit by a car crossing the street 10 years ago. And he had a closed head injury. Maybe that's why, also contributing to his dementia, right? And he often complained of headaches, neck, and back pain. But she says, it's strange. She doesn't talk about that anymore since in the last couple of years, right? Why? Why is he not talking about it? Dementia, of course, right? So we sort of started him off on half of a 12 mic patch. Which I frequently do. Of course, you know why? Because then we don't have to offer him pills all the time, right? Because and then we can kind of say, hi, how are you doing? And just put the patch on every 3 days, right? So we actually got up to 18 micrograms, and resistance to care stopped. He wasn't drowsy. He actually stopped swearing, which the family said was kind of really not like him. But they almost missed it. But we sort of said, hey, this is good because this is the way that he'll manage. So again, I think you understand, but your acute care colleagues don't always understand that as cognitive impairment progresses, people don't complain of pain. That doesn't mean they don't still have it. And I'll never forget a retired nurse with dementia who would say when you'd move her and she'd scream in pain, and you'd say, now, why did you just scream? Because she'd deny pain. She'd say, because I felt like it. And I thought, wow, that's said like a lawyer, never stuck for an answer. And interestingly, she'd say she absolutely didn't have pain, but if you went back to what did she used to do and to the past, she remembered that she'd had back pain. And she said, oh, maybe I still have back pain, and you sort of think, oh, the brain is interesting, So in this one, if things are not making sense, take a more in-depth history, because maybe you're missing something, right? Case 4, this was a very nice 84-year-old Cantonese-speaking lady admitted to acute care. Past medical history, so I was the palliative care person called to see her. She had osteoporosis, previous compression fractures, chronic hypoxemia, hypothyroidism, chronic renal failure. Her CT scan, she was admitted earlier, and it showed a T6 compression fracture that seemed to be new. But since she didn't have any point tenderness over T6, and she was refusing to take Tylenol, they discharged her. Yeah, somebody swore. I agree. Anyways, I'm discharged back to a facility with no change in medication. So the poor facility physician and staff thought, now what do we do? So several days later, she came back in, and she was now on tramadol, trying to do something for her pain, but she was drowsy with little response. And it's Christmas time, and the resident thought she must be dying. I mean, that has no relation to Christmas. But you know what I mean? It's just like unresponsive. What do I do, you know? So palliative care was asked to see, and I was so sad to see how they had dealt with this lady. What might you have done differently? Yeah, but even more basic than that, get an interpreter. Nobody got an interpreter when she refused medications, when when they couldn't make out whether she had pain or not. Do you know what I mean? Like, it's just, it's so basic that you just feel very sad for this poor lady. So I thought, what am I going to do? I thought, well, nothing to lose. I put her on, I knew we wouldn't get any pills down her, so put her on regular hydromorphone and some metoclopramide, because I know that tramadol causes a lot of nausea. And I suspect that she had become drowsy because she was dehydrated, she has renal failure, and she was just exhausted. So patient was smiling and eating next morning, so I bring the resident back and say, here's a good lesson for you, right? This lady was not dying. I don't have to tell you guys, but there's so many problems with that. I just want to point out, though, the fact is that tramadol is known for nausea and hypoglycemia, and that's not the opioid part of the molecule. It's the serotonin noradrenaline part that can cause the nausea and hypoglycemia. As Ted says, for some people it works like magic. But now that tramadol is being used more, I actually saw a study that said tramadol is associated with falls. Made me laugh, because I sort of thought, okay, again, it's one of these big data studies where, you'll see things, and that's why they're seeing problems with gabapentin, because it's being overused. And I totally agree with Ted about the gabapentinoids. I hardly ever use them. And if you remember, they're calcium channel blockers. That'll help you, because then you'll remember why people get the swollen ankles and they get worked up for congestive heart failure when in fact it's the medication. So case number 5, 81-year-old Chinese woman speaks little English, and she had a right-sided hemiparesis. She had been in facility care since 2011, and this was about 3 years. On admission to facility, she was noted to resist care and be agitated, so she wound up on olanzapine, nortriptyline, paroxetine, Tylenol 3-PRN. So you guys all do this. Dementia progresses over the years. She becomes less mobile, less communicative, and the annual care conference notes some drowsiness. So, nobody's got the institutional memory to say, remember why we put her on this? And the team looks at this and said, what's she on all this medication for? So they stopped the olanzapine, they switched paroxetine to citalopram, and they stopped nortriptyline. Does anybody have a comment on that? Yes, absolutely. Yes. So 6 weeks later, palliative care asked to see because she was agitated, eats almost nothing. She was anxious, and she was often taking off her clothes.
Just a puffing sound. Try and do that.
Oh, yeah. He's very particular, isn't he? Okay. But thank you. I appreciate this, and no doubt 500 years later when someone stumbles across this video, they'll notice the puffing. They will, indeed. Okay, so we were asked to see because she was taking off her clothes, she was agitated. Any idea why? What's going on here? So pain could have been restarted. Why would she eat almost nothing? Pain. Well, food is food, isn't it? But yeah, but you never know. Maybe they weren't giving her the food she wanted. What does olanzapine do? I'm thinking. Exactly. Yeah. So the son wanted full investigations and transfer to acute care, just like any good son wants, right? So it was a case of detective work to find out why they maybe had done that. And so what we did is put her back on the olanzapine because we figured they'd probably done it for good reason, right? But what to do about this taking off the clothes? Because even after we restarted the olanzapine and switched her to mirtazapine, which will help her pain, because you realize when they switched her off the nortriptyline and off the paroxetine doesn't do much for pain, and neither does citalopram, but mirtazapine does. But why is she taking off her clothes? Because she has dementia, yeah. Any other reason? Too hot? That's yeah. Although nobody else was disrobing. We did have a lady who, very interesting. She would come out. She could wear a poncho in so many ways, right? I mean, she'd start out here and then it'd be down to here and then here with nothing on above there. And she apparently, when we sorted it out with her, she never wore many clothes at home anyways. So, it's always talking to people about the way they've lived their lives, right, in their culture. So disrobing, what is it when you get neuropathic pain? You have allodynia, right? Remember, where things feel uncomfortable and so on. And what we think, the nortriptyline was probably suppressing that. And so rather than put her back on that, because she was drowsy, she was drowsy, we put her on methadone, 1 milligram Q12 hours, and just titrated it up. I think she was like on 2 milligrams in the morning and 1 in the evening, and that stopped her from taking off her clothes because she was more comfortable. So, so it was a process of discovery. And, it's not the only reason why people take off their clothes, right? But it's something to think about if you can't think of other reasons. So a very useful rule of thumb that I learned was if an older adult gets a new symptom, always think of drugs or drug changes first, because they've usually got so many drugs and you're switching something, or maybe they're getting a side effect. So think of that. And gosh, it's awfully hard to say, but if you can keep a list of diagnoses and their management, if that's possible, that it can survive all the iterations of the chart, and hopefully it will, then you can kind of think, oh, right, this is why we're were using this, because I know polypharmacy drives us all to try and discontinue meds. And of course, you're absolutely right about only doing one thing at a time. So case 6, 77-year-old man who was a tailor in Hong Kong, made those suits over a weekend when people would go there. And he was admitted to residential care after ongoing severe pain and depression for many, many years. And he actually had a decline in cognition. And he complained about pain on both sides of his mouth and his throat, going right the way down. All his teeth were removed in an attempt to treat his pain. I don't know where that was. And he didn't respond to analgesics. He was admitted to psychiatry and treated with ECT, and still no response. He was admitted to residential care because the family couldn't cope. So when I went to visit him, the curtains were drawn around the bed. He was sitting in the wheelchair, banging his head on the bedside table. And he was not able to speak English, but was able, with an interpreter, to say, I have severe pain in my mouth. And it looked normal. And, well, except for the missing teeth. What do you think's happening here? What is this? So pain going all through the mouth and down the throat on both sides? So that's a good sort of pain in the mouth term. Yeah, one could, but it's very vague, right? Doesn't say what's causing that.
Romayne, don't forget to repeat the answers.
Yes, so people are suggesting things like, could it be a terrible trigeminal neuralgia, but that usually manifests as pain on the outside that involves the face as opposed to the mouth. My other colleague suggested a sort of a general term for glossidynia, like pain in the mouth. Anything else that comes to mind? Okay. So we thought, not sure what this is, but I'd seen a few things like this before. And the thing that tipped me off was I started him with methadone, and we titrated up, and we added some duloxetine, and things just didn't seem to be working, right? He was still banging his head on the table, and so on. And it suddenly hit me that this is probably depression manifesting as a physical symptom. And you all know that when you get depressed, you get more pain, and when you get pain, you get depressed. And I've now seen this a number of times where you're thinking they're not responding to anything. What's going on here? And oftentimes it's widespread pain. This was unusual because it was a specific pain. But note that it doesn't make any anatomic or neurological sense, okay? Pain involving the whole mouth and pharynx, that doesn't really make any sense. You can have burning tongue, burning mouth, but this was like on both sides, exactly the same, it doesn't make anatomic sense. So we decided to go for just blasting him with the duloxetine. The unfortunate thing was when he didn't respond to the 12 ECT, people started blaming him. You know how we blame the patient when we can't figure out what's wrong with them? They've got to have a personality disorder. They've got to be just a problem, It was so sad. Anyways, we got up to 120 of duloxetine, despite the very anxious psychiatrist. But, it is in the CPS. You can go that high or a little. We may have gone beyond it. I don't know. But what did we have to lose? Because this poor gentleman had such horrid quality of life. The interesting thing was he still bitterly complained of pain, but he was now outside playing dominoes and smiling. And he would continue to complain of pain if you asked him. And he'd say, oh, yeah, with an interpreter, yes, I have this pain, it's in my mouth. But he was smiling, he was eating, he was interacting with people. And I don't know how many of you have seen this in people with dementia, where you could swear you have their pain under control because they're now up walking around, but they keep saying that their pain's a 9 out of 10. And so, with cognitive impairment, you kind of have to focus on the global picture. So even though he was still complaining of pain, he was functioning so much better, and he looked happier and would even say, yes, he was now out playing dominoes and having a much better time. And I've seen that with other people where they had some pain, but when they got depressed, the pain became all over. And I'll tell you, you can't treat depression if you've got pain, and you can't treat pain if you've got depression. And that's a big problem I find with the Canadian guidelines that sort of say, be careful if you've got a psychiatric illness. I would say, yes, if you've got a psychotic illness, be careful. But if you've got depression, you often need to treat both at once. And if just treating depression won't work if you've also got pain, because this guy needed pretty sort of industrial strength antidepressants. So if patient's pain description doesn't fit a known pain syndrome, think of depression. If it's atypical or widespread, think of depression. And if they're failing all the typical pain treatments, think of depression. Also think of the palliative care concept of total pain. That idea that maybe there's more going on here than just physical pain. And then, of course, focus on function, especially when there's cognitive impairment. Because sometimes if you went by their number scale, you might be fooled. I will hurry up. 84-year-old with renal failure, painful peripheral neuropathy. 50% of people on dialysis have chronic pain. And he was admitted to residential care. He was on hydromorphone 12 milligrams Q, 12 hours for pain. He felt drowsy on these medications, and he had a terrible time after his dialysis because he'd get into severe pain. Why do you think he got into severe pain during dialysis? Yes? Exactly, especially hydromorphone, because it is hydrophilic, and that's the compartment that you're really cleaning out, right?
So the answer for the other side is that dialysis was taking the pain out.
Yes, and history will record that Dr. Becker was very good at, yes. So, thank you. You're absolutely right. So he was being
My dementia clinic's
dialyzed
on Mondays and Wednesdays.
I'll sign up for your clinic then. So, what would you do differently if you could just give him breakthroughs during the dialysis? Couldn't you? Do you think that would make any difference? Yes. So would fentanyl patch work better? Why something continuous? So what's different about fentanyl that we talked about? It's lipophilic, right? So it means that you have a whole store of this medication in your fat compartment. So when you're dialyzed, you've got backup medication there. So yes, you could do that. The other thing you could do, that's dealing with this other problem, is use methadone, because methadone is primarily excreted by the bowel. It's not dependent upon the kidneys. And that's, again, because it's lipophilic. Buprenorphine also is excreted through the gut, too. And so it's also a drug of choice for people with severe renal failure. So we got better pain control, and then we talked, here it was English as a second language, and I think he was a non-complainer. We talked to his renal team, and of course they were happy to adjust things so he didn't have these big changes. And so methadone is a good option. And if you want to learn, what I would say is now apparently they're doing away with the need for a special license for methadone. It's a great drug for older adults. And there's a great online course called Methadone for Pain, 4 with the numeral, Methadone for Pain, that will teach you how to prescribe it. Yeah, methadoneforpain.ca. And it's highly well worth doing. The only drug interactions you need to worry about are the usual bad characters. And so it's the, oh God, here's me and my names. It's the usual like fluconazole and the various antibiotics that you can get into trouble with. But otherwise, there's a lot of potential interactions with methadone, but there aren't really that many. So it really works well. You can get away with using it like a long-acting because its half-life is so long. And you can often treat neuropathic pain without too many other adjuvants if methadone gives them good pain relief. And my favorite combo is methadone and mirtazapine, M&Ms, because oftentimes I find people in that stage of their life don't sleep well, they have pain, they don't sleep well, they don't eat well. Mirtazapine improves sleep, improves appetite, and also helps pain. Yeah.
Yeah, methadone is an excellent drug. It took a palliative care doctor to twist my arm and shame me into getting a methadone license, and I've been treating pain for 20 years. And I just want to mention that the other thing to consider with methadone are two instances. One is it's much less constipating, which is in elderly people, that is a huge problem. And for a lot of people, they'll say constipation is worse than pain for a lot of people. And the second thing I find really a niche for methadone is people are winding up. You just keep going up and up and up and up on their dose, or they were stable for a long time on hydromorphone, morphine, fentanyl even, and as things start to get out of control. And I find that my favorite drug to rotate to is methadone, and it just stops that wind up and just brings everything under control. And I've seen that 20 times. So that's, I don't know if you want to comment about that.
Yeah, no, I agree. It's just that it's interesting because I think what people call hyperalgesia, we would call loss analgesic tolerance, right? Like people will say, it just doesn't work anymore. I need to take more to get the same result. And methadone doesn't seem to have that problem because of the NMDA receptor that it also stimulates. So yeah, it's a good drug and well worth using. So my last point is about topical opioids. So we had this guy who had, the old guy who you think, oh, they've got a basal cell cancer, but he's going to die soon, so we won't treat it. And then 5 years later, it's like a cavity in the guy's face. And what do? And this fellow was having a fair bit of pain with this, as you can imagine. So when you have ischemic ulcers, like the ulcer that you showed, Ted, pressure ulcers, fungating tumors, you can use morphine You can use any opioid because the opioid receptors are present on open tissue, okay, and fungating tumors as well. What I found works best is methadone 1% concentration in an inert wound powder. And we just get it delivered to the ward every day, and you clean, do your dressing change, clean it out, and then just before you put something on, you shake it on, and you spread it around. See how we've spread it around so it covers the whole wound, even the edges. And that gave him great pain relief. Now you might say, but how much of it gets into his system? Actually, we measured some people, it was about 4%. So, and what we found is that we could then usually stop the systemic opioid that we were using to treat the pain, because in a way, if you go directly to the source of the pain, you don't need to use the systemic opioid. So it's a relatively simple thing to do. And that's the end. So questions, comments?
I just want to make one comment. I send people for radiotherapy. I don't care if they're 85 or 90. I've had people with severe, painful squamous cell cancers, keratoacanthomas, basal cell cancers, and I send them for radiotherapy, and it cures it. Pain is gone, right? Especially unless your life expectancy is less than 6 months. So think about active treatment when you deal with people. And the other thing I was just going to mention about the peripheral neuropathy is, and coming into topicals, is that some of the compounded creams are terrific for people with painful diabetic neuropathy. So, let's say they're getting systemic side effects from narcotics or gabapentinoids, whatever you're going to use, that will compound amitriptyline and lidocaine and diclofenac and sometimes baclofen if there's spasm in the neck, and have phenomenal results with that. It's a little bit more costly. Sadly, pharmacare will pay for narcotics and things like that, and they condemn us for using narcotics. When you want to use a topical cream, they say we're not paying for this. And it may cost $100 a month for people, but we've had phenomenal results for people, without the systemic side effects.
But I'd have to add that here's you and I reversing things now. The studies are equivocal. So you may have superb results in individuals, but there hasn't been a lot of studies done on this. So keep that in mind. And, of course, never hesitate to call your palliative care team or call Ted or call somebody when you need some help.
Great, thank you. Questions? Don't forget to push your mic.
Oh, Ted has to turn his off.
Sorry.
So I'm a nurse, and I'm sure lots of nurses here would agree that there's some physicians who don't usually show up to these types of events who are still very adverse to prescribing opioids, even saying, well, we don't want them to get addicted, or we don't want to snow them, or decrease their respirations. And we don't have a lot of, there's not a lot of responses that we generally have to say back. And I was wondering, just as a physician, if you could give some tips to nurses trying to advocate for their patients.
Yeah, we certainly had this problem in our facilities too. So some of the things that our nurses used to use is referring to guidelines, saying you should treat pain, or, opioids are the drug of choice. Of course, it's very hard in this environment with the studies. One thing that could be done, are you a facility director? No. Okay. I wonder sometimes if a facility director could get people to agree on certain standards or certain guidelines, and then you could refer to those, because what we did in palliative care when we had this problem is we would say, we now have a guideline about this, and the guideline indicates that we should treat this pain with an opioid. or we should treat this shortness of breath with an opioid. So that's one way to go about doing it. Do you have access to a palliative care team?
Yes, but it requires the physician's referral.
Oh, how crazy. You've got to fix that. But we did have problems with that. And so the nurses would say, we're going to ask the palliative care team to come and give their opinion, and then can we discuss that with you after?
The palliative care team will not come without a physician's referral. That's not.
Go ahead.
Very interesting.
Yeah, I was just going to make a comment. I don't want to get into arguments about the value of evidence or not. I'm a believer in evidence, not ideological believer in it. But there was a good study that you can use with your physicians and facilities looking at a randomized trial, 2011 BMJ, which randomized people with dementia and agitation to analgesia versus usual care, which was risperidol and antipsychotic drugs. And there was a much better benefit in the people in stepped analgesia with dementia who could not express, like what Romayne was saying, language, cognition, a variety of reasons people can't articulate it. So that's something you can keep in your back pocket and show the physician or show the medical director and say, is this something we should be looking at for our people as a way of trying to get antipsychotic drug use down?
If you want to find that on Google, the first author's name is Husebo, Husebo, and it was a great study. I don't know how she did it. She actually got people with that had no changes for 6 months in residential care, right? I mean, we'd have so many lost to follow-up, i.e. dead, that it would be hard to do. But it's a very good study. And so we'd also do things like that, put studies on the front of the chart for the doctor to see. Do you have access to any ethics?
Yes. Yes. Sometimes, though, you're making that phone call saying this person's in a lot of pain, this hasn't worked, or the family's asking for this, and we're really trying to put it all forward. And I'm not sure how I would say, ask them to consult ethics. Or you get the response, an exact response I've gotten once was, I'm a physician and it's my job to preserve life. And I'm not going to give them something that could kill them. And so you really just feel like your hands are tied then. You're putting it all forward. So it's really that what are you doing next?
Yeah, and this is the problem why I don't believe the evidence that draws increased prescribing to this, and that's because of the palliative care evidence that shows that opioids do not shorten life. In fact, they probably make people live longer. And there's a number of studies that have shown that. Your medical director, I think if you have a repeated problem with somebody, you should talk to your medical director as well.
Yep. Good.
I just want to make one quick point as a hot tip for people. I just do geriatrics frailty care. We see a ton of polymyalgia rheumatica. It's underdiagnosed and treated the wrong way. And especially in a long-term care setting, a lot of people with dementia cannot articulate they have pain. But one of the tip-offs I find are you get these people that get really agitated with care when they're touched. They cannot stand being touched. Do a CRP on those people. We have a case in the community right now who similarly came out of hospital on Seroquel and various antipsychotic drugs and blah, blah, blah. Her CRP was elevated, is on prednisone, and it's gone. And I've seen it many, many times. And the other time you're going to get fooled with this you're old, you've got OA in your neck, and you've got OA in your shoulder, and you've got OA here, and take the Tylenol and take the narcotic, and narcotics do not work well for inflammatory pain. Mm-hmm. Use a steroid, and it's diagnostic to think about that. And similarly with rheumatoid arthritis, that even though you got people in their 80s and 90s, they say don't use steroids, but it's quality of life. And they work quickly, and then people can function, and their quality of life improves. So I just wanted to throw that out there.